Hi everyone. This time I'll talk about action research and face graph. Action research is either research initiated to solve an immediate problem or a reflective process of progressive problem solving led by individuals working with others in teams or as part of a community of practice to improve the way they address issues and solve problems. There are two types of action research: participatory action research and practical action research. Denscombe writes that an action research strategy's purpose is to solve a particular problem and produce guidelines for best practice. Kurt Lewin, then a professor at MIT, first coined the term action research in 1944. In his 1946 paper, Action Research and Minority Problems, he described action research as a comparative research on the condition and effects of various forms of social action and research leading to social action that uses a spiral of steps, each of which is composed of a circle of planning, action, and fact-finding about the results of action. Then I'll talk my quest to empower people to narrate about their health status. When I was a medical student, I did not realize the importance of assessing communication. In hospitals, most of the patients have clear complaints related to one's disease. Medical interviews using appropriate diagnostic questions are usually effective to let patients communicate and give some narratives regarding their illness. Outside hospitals, however, in community health settings, most of the people are not sick. Medical interview techniques are not useful because most of the people do not have obvious complaints. Moreover, in Japan, most people are generally shy and are not accustomed to going into the details of their health status and reveal and express, sometimes narrate about their health. However, in community health settings, obtaining people's remarks or narratives are important in various occasions. That is, understanding health needs of individuals, giving sensitive advices, making suitable health promotion plan, and so on. Therefore, how to help people to express and narrate about their health became my continuing research question since when I started work in the Community Health Department of Nagasaki University in the 1980s. As for the initial trial setting, I focused on the health education setting following community-based health checkup. At that time in Japan, laboratory-oriented numerals and their judgments whether a given value lies within the normal range are returned to each people as feedback. Healthcare providers can relate fragmented meanings of numerals to compose a clinical entity and to make an appropriate clinical decision. Community people, however, have difficulty in conceiving a coherent image of health and wellness from these numerals. In these health education settings, people just sit and listen and say nothing. No conversations, no remarks, no narratives. In this situation, I saw the possibility of assisting people to conceive a coherent image of one's health and start to talk or narrate about their health. And one day, I got an idea of using face graph. Now I'll talk about Chernoff faces. Chernoff faces, Chernoff face graph was invented by Hermann Chernoff. an American applied mathematician, statistician, and physicist. In 1973, he published a paper of displaying multivariate data in the shape of a human face. The individual facial parts, such as eyes, ears, mouth, and nose, represent values of the variables by their shape, size, placement, and orientation. The main idea behind using human faces is that we easily recognize faces and notice small changes. At first, I introduced a simple face graph using a laptop computer to help people's recognition of numerical data. This computer-assisted face graph was, however, not so comfortable for the aged people who prefer numerical communication rather than one-sided appraisal. Then, new idea came up to improve the situation, such as to humanize face drawing process and to enjoy face drawing as a starting point of dialogue between community people and health specialists. To substantiate the idea, a new worksheet was developed to draw a face by hand. By this worksheet, both of community people and specialists can draw a face from a personal laboratory data under the guidance of additional lines. A key point of designing a worksheet is how to assign a specific range of numerical values to corresponding facial features. To solve this problem, Schlesberg's work of experimental psychology was referred. Harold Schlesberg was an American psychologist. Schlesberg classified 72 pictures of the male face using two rating scales: pleasantness, unpleasantness, and attention, rejection. I adapted Schlesberg's first dimension and assigned 3 valued positions to each of facial features. This figure shows my hand-drawn face graph design using a maximum of 7 features which vary. 3 positions A, B, and C of facial features were corresponded to pleasantness, intermediate, and unpleasantness respectively. In applying this face to the actual data, 5 characteristics were selected to correspond to 4 laboratory variables. Then I'll talk about expansion of hand-drawn face graph. In this example, a worksheet is expanded to include other body parts such as trunk and lifestyles such as smoking and drinking. By linking self-checking questionnaire and face graph, respondents are encouraged to self-check their health status and draw the results as face graph. In the next example, a worksheet was designed to focus lifestyle of students. Students are encouraged to use this worksheet and visualize their daily risky behavior. In the case of computer-assisted face graph, only specialists can operate and modify face graph. However, by the use of worksheet, every healthcare professionals as well as community people can design their unique worksheet. The next example shows face graph independently developed by a public health nurse working at Town Fukushima, Nagasaki Prefecture in 1988. After I had started to use face graph in community settings, I realized that people animated to talk about their health checkup results using face graph. In comparison to the traditional calm and silent health education settings, the new setting was chaos. To describe this chaos, many adjectives such as communicative, participative, narrative, constructive, and so on were imagined. To deepen and advance my research perspective, I need to specify and refine key ideas to follow further. One fall day in 1989, my friend Dr. Jun Nishihara, a geographer, suggested me to check the participatory rural appraisal. By this way, I encountered the work of Dr. Robert Chambers and realized that my trial of face graph can be positioned as participatory approach. So far, I have talked about hand-drawn face graph and related research disciplines such as action research and participatory research.